Kia ora koutou, ko Lorraine Ritchie tōku ingoa. I'm Lorraine Ritchie, and I'm very happy and very pleased to be welcoming Dr. Kate Norris to talk with us today about her findings from her doctoral thesis entitled How Registered Nurse Prescribers Influence Collaborative Team Practice. A very relevant topic, and thanks for coming, Kate. Kate has been an RN for 35 years, working in a range of areas. Prior to coming to WellSouth, she worked for many years as a postgrad lecturer in nursing, and she's always been interested in opportunities for advancing the scope of nurses. In her previous role, she worked with a team to develop an academic pathway to nurses to achieve designated RN prescribing, endorsement, and NP scope of practice. In her current role, Kate says she's privileged to have the opportunity to support the primary care nursing workforce, where most of the prescribers sit, I think. In Aotearoa. So welcome, Kate, and thank you very much for coming along to our professional webinar that we run every Tuesday, once a month, the first Tuesday in the month. Kia ora, and I'll go now and hand over to you.
Kia ora, Lorraine. Thank you so much for the invitation, and kia ora koutou to everyone out there that might be listening. Just want to start by acknowledging my supervisors from AUT, Professor Stephen Neville, Professor Marion Jones, and Dr. Kay Milligan. And just a little bit of background, as Lorraine said there, my background prior to coming to work at WellSouth in 2023 was teaching nurses, undergraduate and postgraduate. And I conducted this research sort of spanning across 2018, completing in 2022 as part of a professional doctorate in health science at AUT, as I said. So currently, again, nursing director at WellSouth. So I guess just for the context, the legislation that enabled registered nurse prescribing in New Zealand came about in 2016, so just 2 years before I started this research. Just sort of during the time that I was completing the research, I was privileged to be able to be part of a team that developed the pathway with one of our education providers to our registered nurse prescribing and nurse practitioner scope, which was a really exciting part of my career. So just a little bit of background. For those of you who may not be familiar with our types of nurse prescribers in New Zealand, so we have two types of registered nurse prescribers, completely separate from the nurse practitioner scope of practice. NPs are authorised prescribers and hold their own scope. So for registered nurses, we have registered nurse prescribers in primary health and specialty teams. That's one of the endorsements that Nursing Council manage. So these nurses hold a postgraduate diploma in registered nurse prescribing, and they can prescribe from a very extensive formulary, which includes medications, all the medications for long-term conditions, essentially, and they're required to work in a collaborative team. The second type of registered nurse prescribers that we have are registered nurse prescribers in community health, and this group sort of was introduced in around 2019. So after I'd started my research, and so there are not RN prescribers in community health included in my study. So they complete a Nursing Council approved work-based program, which is they're usually 6 to 7 months in duration, and they can prescribe from a more limited formulary for people who are otherwise well or have minor ailments. And just of note, WellSouth deliver the Te Waipounamu Community Nurse Prescribing Program. So the team that deliver that are in my team currently. So how did this research come about? Well, as Lorraine said, I've had a long-standing interest in advanced scope for nurses. At the time I completed a literature review, I could see that there were many countries and increasing numbers of countries that have implemented nurse prescribing, and that nurse prescribing is well documented to be a safe way of enhancing quality, timely, and accessible healthcare. And the way the countries have implemented nurse prescribing differs hugely. In predominant areas of difference are the degree of medical supervision the nurses require and the medications that they can prescribe. So we've got around the world a range from a very independent nurse prescribing with very few restrictions to where nurse prescribers need to prescribe according to an individualized management plan written by a doctor, so more dependent prescribing, and the exact medications the nurses can prescribe would be stipulated. So the collaborative model that has been introduced in New Zealand is quite different and unique from there are some similarities, but different from other countries. And I was really interested to know what collaborative practice actually looks like in this context. So you can see here the research question and the aims of my study. I was aiming to understand how registered nurse prescribers interact with other members of the team and what are the social processes at play within the team. So I landed on a methodology of critical inquiry. So as I said, the primary interest was the social processes at play, and the research is grounded in a belief or my belief that social hierarchy exists in all human relationships, whether work, in families, and all relationships, and results in an inequitable distribution of power. So critical inquiry enables the research to address power relations. And so I used Pierre Bourdieu, the work of Pierre Bourdieu, who sadly passed in 2002, but he was a French philosopher and sociologist and researcher. I can really relate to his work and would recommend it, but it is heady stuff and took a lot of work for me to really a lot of reading, a lot of time, a lot of reflection to really understand. But essentially, Bourdieu uses these key tools, so habitus, capital, and field, which he describes as thinking tools. So there's thinking tools help us to understand the social context of whatever field or social area we're looking to understand. So practice is taken for granted, and I'll talk about this a lot, where we take these power relationships, particularly in our workplace and families, wherever we are, for granted. They are just the status quo and what we expect to see. So just really, really briefly, because I don't have long today, to talk about the thinking tools. So habitus, I think of habitus as the who we are. So these are the embodied dispositions, the attitudes, our interests, beliefs, tastes, values, all the things that shape our actions and perceptions in the world. And we can have a group habitus. So, we can have a nursing habitus, for example. So that's our dispositions. And then we have capital. Capital is the resources that evoke power. It's the things that we have, and Bourdieu sort of classified these into cultural capital, social capital, symbolic capital, economic capital. So all these different forms of capital hold greater or lesser power depending on the field that we're in. So they're unique to the field or the social context. So these things really contribute to locating a person or a group within a social hierarchy. Okay, so using critical inquiry and Bourdieu's methodology, just a little bit about the design of the research. So it's qualitative. I selected 3 teams that all included a registered nurse prescriber, and then conducted very semi-structured interviews with 5 members of each team. So they were GPs, consultants, registered nurses, registered nurse prescribers, nurse practitioner, pharmacists. So just depending on who worked in the teams that were chosen. And some observation of team meetings, but a surprise finding for me was that many of the teams didn't actually have team meetings. So the findings, I could probably sit here for days reporting or presenting the findings because there were a lot, but there were sort of 3 overarching ones. And so today I'm just going to speak to one of those. So there was, as you can see there, social topography, which we'll talk about now, I'll talk about now. There were perspectives of working with a nurse prescriber and the patterns of communication. So, social topography, just some key points to start with. And I just want to make the point. So social topography means that in each team, individuals occupied a position classified according to professional discipline. So such as a GP, they're a consultant, a registrar, a clinical nurse specialist, a registered nurse, or a registered nurse prescriber. And many of you will be thinking, well, that's pretty obvious, isn't it? And may seem, convenient. However, this finding is really grounded in the data, and you'll see examples coming through when I share them. So this really informs the common belief or popular opinion, and in my mind has quite a meaningful impact and leaves us with something to really think about, how we maybe break down some of our traditional beliefs around those roles when we consider that prescribing has always sat in the past with doctors and more recently nurse practitioners. So attached to each of these disciplines are these collective institutionalized expectations, and attached to this system of classification are the resources available, the remuneration available to each person within these disciplinary groups, the opportunities and responsibility that's distributed according to this taxonomy by professional discipline. The system perpetuates and reproduces hierarchy within teams. And it's very much ingrained in the habitus of all team members. And before I mentioned, we have a group habitus as well. So as nurses, we have a group habitus. We, obviously I'm speaking from the place of a registered nurse. We understand our place in the system. We understand what's available to us, resources available to us, and our potential based on this. The social order is very much taken for granted, and Bourdieu would call it the doxic order. So what I'm going to do now is just share findings from each of these teams. I'll tell you a little bit about each team as I go through, and I'm hoping that in sharing words of the participants, this will illustrate this theme of the classification by discipline. So Team 1 is a large urban general practice, around 15 GPs, no nurse practitioners, and it's privately owned by a subgroup of those GPs. The registered nurse prescriber in this team was restricted to prescribing in diabetes only. So back in the early days of registered nurse prescribing, the first nurse prescribers were diabetes nurse prescribers. And so that category of nurse prescriber is no longer available for entry on the Nursing Council register, but we still have nurses that are restricted to prescribe in diabetes only. So in some cases, the GP, the nurses working with on a particular day is a practice owner and the employer. And this really impacts the employee's sphere of influence. As you can see, the nurse saying here, we're working shoulder to shoulder with the people who pay us. So there's a really interesting dynamic at play. You want to treat your employer with a lot of respect. And for me, this puts them, the GPs, into a hierarchical position. So you can actually see that sort of power imbalance coming out in the RN's words. In this practice, so every team, as I said before, very unique and different. The nurses, the GP here is talking about the nurses. He was saying to me that he thinks that they're quite progressive in the practice now, but it was interesting, as he was telling me this, he was referring to skills and tasks. So they do technical things, ECG, spirometry, sleep studies, well child checks, and giving IV medications. They take responsibility for all that and coordinate it. So they're acting as practitioners in their own right. So a real understanding that skills and tasks delegated by the GPs was the realm of the practice nurses in this team. Next, I just want to talk a little bit about the experience of the GPs, or the perception of the GPs around the introduction of registered nurse prescribing. So there was a sort of sense of loss. Whilst they had supported this nurse to become a prescriber in the team, there was a sense of loss and losing some autonomy. So here in number 3, nurse practitioners, physios and podiatrists and other specialties are all chipping away at general practice and taking things. He talked about the midwives, they've taken obstetric care. So this real sense that the traditional role of GPs had been gradually eroded by other healthcare professionals. Also, this possibility that we'll get de-skilled in diabetes and doctors will lose confidence because they're not doing it, and that they'll lose their cultural capital. That they may also lose their autonomy over patient care. So if you consider that the patients are enrolled under the name of a general practitioner, you can see that coming through. A doctor can feel ownership of a patient, that they're my patient, and the doctors are very prickly about losing patients to other people. And this became obvious talking to the registered nurse prescriber, whereby she said that different, you can see in the quote here, number 6, every GP works differently. Some are happy for me to go ahead and they have trust that I will do the right thing and I'll let them know what they need to know. Whereas others would want me to discuss my plan with them before I do anything. And some GPs like to manage their own little world and they don't really want me to intervene at all. So that registered nurse prescriber worked to the particular needs and desires of all of the 15 GPs in terms of her uh, ability to work to the full extent of her scope. So just in summary, in Team 1, there's an equitable distribution of capital resulting in power differential. The GPs were holding a dominant role, leading care, delegating tasks to nurses, and deciding whether to involve the nurse prescriber at all. So you can see that the GPs are determining the value placed on nurse prescribing in this team. And this is the toxic order of the team, and it's not challenged. It's not seen as a bad thing. That nurse prescriber was very, very, very happy in her role and happy to be prescribing in that team. So then we'll move to team 2. So Team 2 also is a general practice team in primary care, but quite a different context and a much smaller team, a small team, situated in an economically deprived urban area. The practice is owned by an external party, so you can see a difference here. They're not employed. So the practice owners are not employed within the team. They're not healthcare professionals within the team, and they're not closely related to the daily running of the team. The practice is supported by the government's very low cost access scheme, and it's a not-for-profit business. So quote in the first quote there, you can see the registered nurse describing the team. I think we're all committed to justice issues working in a place like this. We have a passion for the people who live in this area and the equity issues, and I guess that colours how we do things. The team talked about it not being an easy place to work, limited resources, and a challenging community needs due to them to being a very deprived community. So I guess the impetus for their work is very different from the previous team I spoke about. The inclusion of a nurse practitioner in the team had been very enabling for the introduction of registered nurse prescribing. The nurse prescriber talked about how she couldn't have done it without the nurse practitioner's support. And you can see that the NP has championed nursing, I think. When she came here a few years ago, I think she broke the back of it, really showing the GP what nurses can do. And when she talks about breaking the back of it, she's referring to just a little bit of pushback, a little bit of, maybe not pushback, a little bit of concern and apprehension from the lead GP about working with the nurse practitioner. But there was a real sense of over time and after he'd worked with the nurse practitioner, it really changed his impression and his view of working with advanced scope nurses. And that's something anecdotally that I hear a lot in my role is from GPs who say, gosh, now that I've worked with the nurse practitioner, I wouldn't look back, sort of thing. So that really made a difference to the implementation of nurse prescribing in that team. And the words of the GP, everything's about time. I can't see how we can lose. Having nurse prescribers, if you want to be mercenary about it, will allow us to see more people, enroll more people, and therefore increase income for the practice. So a real concern about how we keep the doors open to serve the needs of this community, and an appreciation that nurse prescribing and nurse prescribers increase the revenue earning potential of the practice. And then number 4, you can see this real challenge to her sense of place for the nurse prescriber. She said I thought I loved the wording. She said, I feel like Piggy in the middle. I'm doing nursing stuff and I'm doing prescribing stuff and I'm helping the doctors and I'm helping the nurses and I'm just getting used to the new role because we really weren't sure how it was going to work in practice. So I did hear that over and over again in all three teams. There was no real plan of how we were going to implement this role. In team two, the registered nurse said, lots of the casual nurses, they really want to come back and work here. We have more autonomy. We do more than just taking blood and giving vaccination. So there was a sense this team felt that they were moving away from what could be perceived as a traditional practice nurse role or more of a delegated task-based role like in team one. And this really enhanced their sense of job satisfaction. In fact, they talked about their team as being nurse-centric in that on many days they would have nurse practitioner and nurses and not a GP. In team two, the registered nurse prescriber had the trust and the freedom to trial different ways of working, different approaches to implement her role. So she talked about being opportunistic. I really liked this quote where she said, last week she saw a lady who was diabetic and she'd been trying to see this patient for some time. I hadn't been able to get her to come into the clinic. And then she spied her in the waiting room with her husband and she just sort of said, look, I'll come with me and I'll see you now. And she spent lots of time and managed to do lots of assessment and just checking on medications and meeting this woman's needs. She then said, I haven't been able to get in touch with her again since, but it really enabled quite an opportunistic way of working. So in summary, in team two, we can see the presence of a nurse practitioner has catalyzed change in social positioning. So the nursing knowledge and nurse prescribing is really valued and actively encouraged. Nurses are actively encouraged to be involved in clinical decision making rather than just in completing tasks. So the third team, quite different. So a specialist practice. So they provide outpatient specialist care within a large urban hospital. And in that team, there were 3 medical specialists or consultants, a clinical nurse specialist who was an RN prescriber and a registered nurse. So the first quote, you can see the main consultant is fantastic. He's supportive of whatever nursing wants to drive. He's proactive in supporting my RN prescribing. He's very keen to see nurses working to the absolute top of their scope. It was very clear to me that those consultants were considered to have, the lion's share of cultural capital. Their knowledge was held in extremely high regard, and it was very clear that if that lead consultant had not been supportive, that nurse would not be prescribing in practice. His words there, very comfortable with prescribing, given I've worked with Sarah, who was the prescriber for many years. She's appropriately experienced with very good insight into conditions and into the drugs and how they work and how they use them. So of note, that nurse prescriber had worked in that service for 10 years. That social capital, that relationship, long-standing relationship with medical consultants in the service, that social capital was really valuable for her in enabling her to become a prescriber. And I guess in contrast, these words from the registered nurse in the service, where she says, I'm kind of at the bottom of the hierarchy. It's not always easy and it's not what I want to climb. It's not what I want to climb to the top by any means. I would just like to climb up here instead of down here, she said. I'd like to sort of be somewhere in the middle. She'd worked in the service for 4 years. She wasn't new, although she called herself a newbie. And you could just really see by those words her sense of her place in that social hierarchy. Again, in Team 3, we can really see that nursing knowledge is valued. We bring a different perspective than medicine. There's a mutual respect for each other's knowledge and the combined knowledge of what we bring to the service to enhance patient care. So for Team 3, in summary, the RN prescriber has earned the trust of the esteemed consultants who occupy the top tier of the social hierarchy, and the consultants are determining the value of nurse prescribing. So this is symbolic capital. So symbolic capital equates to authority and respect, and it's legitimated by the team. So so that's some of the findings in the participants' words. Back to a little bit of Bourdieu now. So what does this mean? So the impact of this quite pervasive system of classification by discipline impacts the objective organisation or the organisational structure at play in each team. So you can see I've written there the allocation and the organisation of work. So what patients the registered nurse prescriber can see, in what situations, how they're all women in this case, how their time is allocated, how their consultation times, where they see patients. If you think about general practice, in both situations, the registered nurse prescribers were working sort of on the floor and from a collective practice nurses space. The GPs were working and the nurse practitioner were based in their own private office. So you can sort of see the fallout of the system of classification impacts structure and the way people work. So these ways of working become ingrained in the subjective structures or the habitus of all team members, including the nurse prescribers, and that impacts what they see as possible in their role. So our discipline is an important part of our identity and impacts the way we behave in teams. And so you can sort of see the circle continues and the status quo continues. So it's a dialectical relationship. So my challenge, I guess, and my recommendations, just to finish up, are I was going to put in a quote there from Henry Ford where he says something along the lines, if we always do what we always did, we'll get what we always got. I guess my point is that just by simply putting a nurse prescriber in a team, it doesn't mean that the team will work differently, or that that nurses will really be able to work to the top of scope, or that to really enable positive change through their prescribing. So my challenge is that registered nurse prescribing offers an opportunity for innovation and thinking beyond traditional models of care delivery. And so in order to make that a reality, I think we need to consider teams really need to do some forward thinking with the team before including a registered nurse prescriber. And all three teams in my research and in what I'm seeing very often in primary care is that it's the registered nurse, his or herself, that have driven the process. They have seen the value in becoming a prescriber. They've enrolled themselves and got some funding in postgraduate study, and then they've got prescribing endorsement, and then tried to implement that into the team the best that they could. But some forward thinking in terms of socializing the prescribing role. My experience is that many healthcare professionals, including including nurses, some nursing colleagues, don't really understand the role, the accountability, and the extent and the scope. I would recommend seeking support and the mentorship of nurse practitioner colleagues and other advanced practice nurses, because as I illustrated earlier, that having that person to champion is hugely beneficial. I mentioned earlier thinking outside of the box about how to best use space. And now that I'm sort of working with primary care colleagues, I can see different ways of working. Office space is at a premium in all of just about all general practice offices. So, thinking about maybe it's better to have the nurse prescriber in a space seeing the patient and having that very limited resource of the nurse practitioner or GP floating and being able to assist the nurse prescriber when needed. I don't know, just thinking different ways of booking time, making sure that whoever's booking the appointments for the nurse prescriber really understands the role and the sort of patients they can see, and so that they are seeing the people they really need to see. And this is really came from another theme, but incredibly important outcome from my research was just enabling opportunities for dialogue. As I said, there were often not meetings within the teams. Nurse prescribers need to be able to talk with other prescribers. They need to review cases and be involved in shared decision making that builds trust. Finally, just a plug for interprofessional education. So learning about, from and with each other, I think is really important. And that's that. Sorry, Lorraine, I went a little bit longer than I thought I would.
That's quite all right. Kia ora. Thank you, Kate. Does anyone have any questions for Kate or comments? You can put them in the chat. Thank you so much, Kate. That was really quite fascinating, going into the world of general practice and primary health, which is different to where I work, but some of the people listening, they may work in that environment as well. But regardless of that, as you say, with the critical theory lens, with Bourdieu's work of social capital, hierarchies of power and ways of working, that exists in every workplace, I think. But for you, the focus was on the nurse prescriber. And I do notice now, just hearing people in the community say, oh, I went to the doctor, I went after hours, and I say, who did you see? And they say, I saw the nurse prescriber. And I never, ever would have heard that, people saying that before. So they've kind of become a recognisable figure, I guess, or person in the general practice team. So that's quite exciting. And as you and I were saying earlier, with Jill Clinton now being contracted to nursing council, to look at nurse prescribing, there may well continue to be changes in this space. And but really fascinating. And like all research, when you read people's quotes, when you hear people's quotes, it really brings it out, doesn't it? Like the crunch of what's happening there and what people are feeling and thinking. And yeah, that was quite fascinating. Thank you very much. I don't think we have got any questions, but Kate, if people wanted to contact you, how would they do that?
They can email me, kate.norris@wellsouth.org.nz.
Great.
I'm always very
sorry,
happy.
there is a comment, and it says, Kate, I'd like to invite you to speak at our nursing legal ethical workshop in Invercargill. And that's from Nick. And I could give you her contact. I think it's Nick Dowling. It will be.
Oh, sure, Nick. Yeah.
But anyway, she will get in touch with you, no doubt. Sorry, it's Nick Branson. Sorry, Nick. Getting my Nicks muddled up. So yeah, that sounds very appropriate, and you'd be fantastic at that forum. I've spoken there before, and I think they would really enjoy that. So I can give you Nick's email address, and people can contact you by email.
Absolutely.
Which is
Always
great.
happy to talk of all things advanced scope for nurses. Yeah.
Fantastic.
Thanks for inviting me.
Thank you so much. Kia ora.
Kia ora.